This talk is about leg somatosensory evoked potentials. It is intended for the clinical neurophysiology fellows at Nicklaus Children's Hospital. It will be conducted in a question and answer format. The first question is, leg somatosensory evoked potentials include posterior tibial and peroneal nerve studies. A true, B false. Leg somatosensory evoked potentials are most often done using the posterior tibial nerve, less often using the peroneal nerve, and only rarely using other leg nerves. The term posterior tibial nerve somatosensory evoked potential requires some explanation. You would expect that if there is a nerve called posterior tibial nerve, that somewhere there would be another nerve called anterior tibial nerve. Well, that is not the case presently. But as you can see in this frame, in the past there was. But the name has been changed, and the new name is deep peroneal nerve. So there was no longer a reason for the posterior tibial nerve to be called posterior. And its name was then changed to tibial nerve. This name was given to the nerve proximally as well as distally. So probably you would assume that from then on, neurophysiologists would talk about tibial nerve somatosensory evoked potentials. But neurophysiologists are not the changing name type of people, and we still use the term posterior tibial nerve somatosensory evoked potential. The story regarding peroneal nerve somatosensory evoked potential goes in the same general lines. We talk about peroneal nerve somatosensory evoked potentials when referring to common peroneal nerve somatosensory evoked potentials. Furthermore, the name common peroneal nerve was changed, and currently we are calling this nerve the common fibular nerve. So again, you would suspect or assume that neurophysiologists would refer to the somatosensory evoked potential of this nerve as fibular somatosensory evoked potential. But we do not. We still call it peroneal nerve somatosensory evoked potentials. So the answer to this question is A. Next question. Leg somatosensory evoked potentials can be done at many locations. A true, B false. In addition to these two nerves that we have just talked about, somatosensory evoked potentials of the legs can be done using other nerves, as I will show you in the next frames. The location of the stimulus in this study is indicated by the arrows. The spinal segments are also labeled. The test was done in both legs. The patient had a prolapse of the intervertebral discs at the level of L3 and L4, producing spinal canal stenosis. As you can see, no response was present in the left L3 study. This is particularly noticeable when you compare it with the L3 study on the right. The left L4 response was delayed and greatly reduced, especially when you compare it with the right one. Thus, it was confirmed that the abnormality that was initially noted in the left posterior tibial nerve somatosensory evoked potential was present. At this point, please compare the result of the evoked potential in this nerve on the left with the one on the right. I like to take the advantage of this figure to remind you that L5 dermatome is in the dorsal and external aspect of the big toe, and that the impulse from this area travels through the superficial peroneal nerve, and also that a stimulation of the S1 dermatome travels through the sural nerve. So the answer to this question is true. Next question. The stimulus for posterior tibial nerve somatosensory evoked potential is done behind the medial malleolus. A true, B false. The point of a stimulation in posterior tibial nerve somatosensory evoked potential is chosen by finding the posterior border of the medial malleolus and the medial border of the Achilles tendon at the same level, as it is shown in this figure. Then, by drawing a line between these 2 points and placing a vertical line through the middle of the horizontal line previously drawn, and at the insertion of these 2 lines placing the cathode, the anode goes distally. So once the stimulus point is selected, the duration of the electrical square pulse should be set at 200 to 300 milliseconds, and the intensity should be adjusted to produce a plantar flexion twitch, mainly of the big toe, which usually occurs at about 20 to 30 milliamps. The repetition rate should be from 2 to 3 per second, and the usual repetition rate is about 2.7 per second. The number of trials needed to have a clear evoked potential in the legs usually goes from 1,000 to 4,000 trials. So the answer to this question is true. Next question. During posterior tibial nerve somatosensory evoked potential, the cathode should be placed distally. A true, B false. I hope you got this one right. The cathode should go proximally in the direction you want the current to go. So the answer to this question is B. Next question. The stimulation of the posterior tibial nerve activates the mesial segment of the posterior paracentral gyrus. A true, B false. The landmarks of the mesial aspect of the brain are not as consistent as those in the lateral aspect of the hemispheres. A relatively easy identifiable sulcus in the mesial surface of the brain is the marginal sulcus. which is often a continuation of the easiest identifiable sulcus of the medial brain, which is the cingulate sulcus. Anterior to the marginal sulcus, and often, as it is in this case, arising from the cingulate sulcus, we find the paracentral sulcus. And somewhere in the middle, between the marginal sulcus and the paracentral sulcus, we find the central sulcus. Behind the central sulcus, we find the posterior paracentral gyrus. And anterior to the central sulcus, we find the anterior paracentral gyrus. The anterior paracentral gyrus corresponds to the Brodmann area 4, and the posterior paracentral gyrus corresponds to the Brodmann area 3, 1, and 2. In this cartoon, representing a brain cut coronally through the posterior paracentral gyrus, I have encircled the area corresponding to the foot. I have done this to give you an idea of the size and the location where it is. Now I am presenting back the cut of the brain in the mesial aspect to show you the approximate area occupied by the foot and the lower leg sensory area in the posterior paracentral gyrus. I have highlighted that area in green. So the answer to this question is A. Next question. The stimulus for peroneal nerve somatosensory evoked potential is usually done over the medial plantar aspect of the foot. A true, B false. Hopefully you remember from the beginning of this talk that the stimulation for peroneal nerve somatosensory evoked potential is usually done at the back of the knee. With the cathode proximately, as you can see in this example. So the answer to this question is B. Next question. Which stimulus site produces higher amplitude cortical potentials? A. At the level of the popliteal fossa. B. At the level of the foot. An stimulus to the common peroneal nerve at the knee activates nerve fibers from muscles in the lower leg and foot, as well as a large contingency of sensory fibers from the same areas. An stimulus of the superficial peroneal nerve at the ankle only activates foot sensory nerve fibers. In the distribution of the dorsum of the foot. So the stimulation of the superficial peroneal nerve produces peaks with maximal amplitude of about 2 microvolts, whereas stimulation of the common peroneal nerve at the popliteal fossa produces smaller amplitude peaks, as you can see, of 1 microvolt. This occurs despite the fact that more fibers are activated when the stimulation is at the popliteal fossa than when it is at the foot. This paradoxical situation where a smaller number of stimulated fibers produce a larger scalp field than the stimulation of a larger number of fibers is the result of cerebral anatomy at the level of the mesial surface of the posterior paracentral gyrus. At least this is what we believe. We think that what happens is that the proximal stimulation, that is a stimulation at the level of the popliteal fossa, produces field in multiple directions that cancels out each other. As I have attempted to demonstrate in this frame by representing green arrows going in multiple directions. On the other hand, when the stimulation occurs at the ankle that is involving the superficial peroneal nerve, the field is more compact, thus producing a field that ends up being more readily captured at the scalp. So the answer to this question is B. Next question. The ground electrode for leg somatosensory evoked potential should be placed in the forehead. A true, B false. The ground electrode, when conducting a posterior tibial nerve somatosensory evoked potential, should be placed at the mid-calf or in the thigh when doing a common peroneal somatosensory evoked potential. Remember that the same ground electrode should be used for the stimulator and the amplifier. So the answer to this question is B. Next question. The regular montage recommended for posterior tibial nerve somatosensory evoked potential by the American Academy of Clinical Neurophysiology includes all of the following electrodes except A. CPI, B. FC, C. FPC, D. IC. The American Academy of Clinical Neurophysiology recommends that at least 4 channels be used for posterior tibial nerve somatosensory evoked potentials. The first channel connects an electrode on top of the spinous process of T12 to an electrode in the iliac crest opposite to the site of the stimulus. It yields a peak labeled LP for lumbar plexus or lumbar point. The second channel connects a mid-prefrontal electrode to an electrode on the spinal process of C5. In this derivation, we can recognize 2 peaks. One is P31 and the other one is N34. The third channel connects an electrode on the mid-centroparietal area with an electrode in the mid-prefrontal region. The channel captures a peak called P37, which is by far the most important peak when we are studying or analyzing posterior tibial nerve somatosensory evoked potentials. The fourth channel connects an electrode over the ipsilateral centroparietal area with a mid-prefrontal electrode. This derivation also captures a peak labeled P37, which is generated by the same neurological structure than the one that we talked about it when we were referring to the third derivation. In this frame, I have removed all the waves in order to be able to add the figure corresponding to the 1020 system electrode placement. I have done this to highlight the position of the scalp electrodes. The electrodes signaled by the arrow correspond to CPI in virtue of its location in the 1020 system arrangement and being on the same side of the stimulus. The electrode indicated by the arrow corresponds to FPZ. The electrode indicated by the arrow in this frame corresponds to CPZ. And now I have removed those figures, that is the figures of the 1020 system arrangement, in order to show you a figure of the location of the non-cephalic electrodes. These electrodes include one at the C5 spinous process, another at the T12 spinous process, and a third one in the iliac crest. So the answer to this question is B. Next question. The extended montage recommended for posterior tibial nerve somatosensory evoked potential by the American Academy of Clinical Neurophysiology monitors the sagittal, ipsi, and contralateral centroparietal regions. A true, B false. The extended montage recommended by the American Academy of Clinical Neurophysiology includes 8 channels. The first channel surveys the peripheral nervous system by capturing the traveling electrical activity as it ascends in the tibial nerve at the level of the popliteal fossa. The D stands for distal and the P for proximal. The proximal electrode is placed 5 centimeters above the popliteal crease, as indicated by the arrow, and the distal electrode is placed at about 2 centimeters above the popliteal crease in the middle of the fossa. Or it can also be placed by the side. When that is done, it's best placed by the medial side, that is close to the medial femoral trochanter at the insertion of the tendon of the semimembranous muscle. The second channel connects an electrode on the second lumbar spinal process to another non-cephalic reference. The third channel connects an electrode on the 12th thoracic spinal process to a non-cephalic reference. The fourth channel connects an electrode corresponding to the 10th thoracic spinal process, again connected to a non-cephalic reference. The fifth channel connects an electrode from the mid prefrontal area to an electrode on the 5th cervical process. That electrode, the one in the 5th cervical process, is not shown in this figure. The 6th channel connects an electrode at the ipsilateral centroparietal area, which, depending on the stimulus site, could be the right or the left side, but for simplicity's sakes, I will make it in this frame on the left. So it will connect an electrode on the left centroparietal area to an electrode in the sagittal prefrontal area. The 7th channel connects an electrode in the sagittal centroparietal area to an electrode in the sagittal prefrontal location. And the 8th channel will connect an electrode from the centrolateral contralateral area. Let's make it the right centroparietal electrode in this frame to an electrode on the sagittal prefrontal location. In this frame, I am displaying the position of FPC in relation to the brain. And I am doing the same thing here for CP4 which corresponds to either CPI or CPC depending on the site of the stimulus, CPZ, and CP3 that could, I hope it's obvious to you, be either called CPI or CPC. The last three electrodes become important when the P37 peak is not detected at the expected location, which is the ipsilateral centroparietal region, that is ipsilateral to the stimulus. So the answer to this question is A. Next question. What does CZ apostrophe stands for? A, ZC, B, CZ plus 1 centimeters in front, C, CPZ, D, CI. The K in this frame stands for knee, which corresponds to the medial trochanter. The UM for umbilicus. The CV6 stands for spinous process of the 6 cervical vertebra. The C with an apostrophe corresponds to CPZ. The CI stands for ipsilateral ear. Frontal ipsilateral corresponds to F3 or F4. And frontal contralateral, that is FC, corresponds to F3 or F4 contralateral to the stimulus. PI and PC correspond to CP3 or CP4. Names followed by apostrophes imply different things. FC apostrophe implies location between FC and CZ. C3 apostrophe corresponds to PC3. C1 apostrophe corresponds to CP1. CPC apostrophe corresponds to CPZ. CP2 apostrophe corresponds to CP2. CP4 apostrophe corresponds to CP4. So the answer to this question is C. Next question. The montage used for posterior tibial nerve monitoring is the same by all authors. A true, B false. This panel was used in a prior question to highlight the discrepancy in nomenclature used by different authors. And now I have brought it back to show you the discrepancy of montages used by different authors. Compare the montage on your left with the montage on the right, which is the one that is recommended by the American Academy of Clinical Neurophysiology. As you can see, the electrode nomenclature, peak labeling, and channels used are very different. Notice that both of these publications from where I got this montage were written or were published the same year, on 2008. So the answer to this question is B. Next question. The vector of the force created at the mesial segment of the postcentral gyrus due to activation of the posterior tibial nerve is most of the time directed towards the opposite hemisphere. A true, B false. This cartoon represents a coronal cut through the posterior central gyrus. Activation of the cortical area serving the foot and toes following posterior tibial nerve stimulation produces an electrical field with the vector straight forward towards the opposite hemisphere, as I have drawn here or represented by the arrow. At times, it tilts a little bit upwards, or frankly upwards, and rarely the vector is directed towards the same side of the cerebral cortex being activated. I have indicated this by the aqua arrow. In the next frame, I will show you an example of this variability. Here, in the lower figure, the left ankle is being stimulated, and in the top figure, the area of the cortex activated is indicated by the green lines. The vector of the field is directed contralateral to the stimulus. I have now introduced a montage with 7 derivations. Notice that in the CPZ to FC derivation, P37 is hardly a wave, and it is labeled by choosing the base of N45. But it is clearly seen in the CP4 to C5S derivation. Here, the stimulus is now given on the right. The vector of the force is again directed contralateral to the stimulus. In this instant, P37 is clearly seen at CPZ FPC derivation, but is more marked or better seen in the left centroparietal region. That is, in the derivation that goes from the left centroparietal region to the posterior cervical electrode. So, with left stimulation, the evoked potential was maximal at C4 to C5 derivation. With right stimulation, P37 was best seen at the CP3 location, that is contralateral to the stimulus in both situations. This is not the typical localization of the posterior tibial nerve P37. Posterior tibial nerve P37 is usually present ipsilateral to the stimulus site and contralateral to the activated hemisphere, which is the opposite of what happened in this study. So the answer to this question is A. Next question. The regular montage used for posterior tibial nerve somatosensory evoked potential includes electrodes to monitor peripheral tibial nerve activation. A true, B false. As you can see in this frame, the popliteal fossa, that is the posterior tibial nerve as it travels through the popliteal fossa, is not regularly monitored by the usual posterior tibial nerve montage used. But in the extended montage, it is monitored. So the answer to this question is B. Next question. Which of the following peaks is the result of a traveling field capture using a bipolar montage? A, B, or C? Let us consider EP first. So the derivation consisting of ipsilateral earth point to contralateral earth point allows us to see the earth point wave. This is so because the activity at EPI is compared with the activity in an area where there's no activity related to the stimulus, that is on the opposite earth point. This derivation is not considered bipolar since the same field is not monitored by the two electrodes. It is nevertheless a near field because minor displacement of the exploring electrode connected to the grid 1 of the differential amplifier and arising from EPI produces significant changes in latency, morphology, and amplitude of the registered wave. Now let us consider LP. The LP peak is likely the result of a combination of traveling and fixed generators. The T12 to IS derivation is not a bipolar derivation, but it is a near field because of the reasons that we previously mentioned when we were talking about EP. Now let us consider PF. PF stands for popliteal fossa. The popliteal fossa recording captures the wave as it moves through the nerve. It is a bipolar recording because both electrodes are influenced by the same electrical field. And it is a near field because any change in electrode position will alter latency, amplitude, and morphology of the wave. This will be so regardless of the electrode that is changing position because of the proximity of both electrodes. So the answer to this question is C. Next question. The time per division used for median nerve and tibial nerve somatosensory evoked potential is the same. A true, B false. This is a median nerve somatosensory evoked potential. Each division is 4 milliseconds. And since there are 10 divisions, the analysis time is 40 milliseconds. This is a posterior tibial nerve somatosensory evoked potential. The green arrow indicates a division. In this case, each division is 8 milliseconds. So the analysis time for this study is 80 milliseconds. So the answer to this question is B. Next question. The FPC-C5S channel when doing left tibial nerve somatosensory evoked potential will capture P37. A true, B false. In this derivation, FPZ is connected to C5S. When recording during a left posterior tibial somatosensory evoked potential as indicated in this frame, this derivation will detect two peaks, P31 and N34. FPC will capture P31 and N34. C5S is a silent electrode. Therefore, it will not add or subtract any waves to those captures by FPZ. So the answer to this question is B. The CPZ C5S channel, when doing left tibial nerve somatosensory evoked potential, most of the time will capture an isolated P37, A true, B false. The CPZ to C5S derivation, when doing a left posterior tibial nerve somatosensory evoked potential, will usually capture three peaks: P31, N34, and P37. The waves picked up by CPZ are all the waves that I just mentioned before, whereas C5S does not add any wave since it is a silent electrode. So the answer to this question is B. Next question. ZPC to FPC channel and CPZ to C5S channels, when doing left posterior tibial nerve somatosensory evoked potential, will capture the same peaks: A true, B false. Let us first consider CPC and FPC derivation. Using this derivation, the only wave recorded will be P37. This is because CPZ in a significant number of patients will capture P31, N34, and P37, whereas FPC will only capture P31 and N34. These waves, by virtue of entering the differential amplifier through the input 2, will be inverted, thus cancelling out the P31 and N34 entering through input 1. Thus only P37 will be recorded. Now let us consider the derivation going from CPZ to C5S. The CPZ electrode is connected to the input 1 of the amplifier, and CP5S is obviously connected to the input 2 of the amplifier. Such derivation and arrangement will encounter three peaks: P31, N34, and P37. The waves picked up by ZPZ are P31, N34, and P37. And C5S will be silent. It's important to remember that C5X is silent only in leg somatosensory evoked potentials, but not in upper extremity somatosensory evoked potentials. So the answer to this question is B. Next question. Which of the following waves will be recorded using CP3 to CP4 in most patients during left posterior tibial somatosensory evoked potential? A. P31, B. N37, C. P37, D. P31, and 34. In most patients, activation of the foot and toe by stimulation of the posterior tibial nerve generates a cortical field directed towards the opposite hemisphere. In a few patients, activation of the same area generates a field with a vector towards the same hemisphere as the cortical activation occurs. Whether it occurs one way or the other way is a consequence of the anatomy of the area. Thus, in the majority of people undergoing posterior tibial nerve somatosensory evoked potentials, when the ipsilateral parasietal centroparietal electrode is connected to the input 1 of a differential amplifier, and the contralateral parasietal centroparietal electrode is connected to input 2 of the same amplifier, the only wave that will be captured will be P37. This is because CP3 will capture P31, N34, and P37 in most individuals, whereas CP4, the electrode contralateral to the stimulus and on the same side of the mesial cortex being activated, will only capture P31 and N34. That, when inverted by virtue of entering the amplifier through its input 2 slot, will cancel CP3 captured P31 and N34, since P31 and N34 are far fields, thus allowing us to visualize P37 alone. So the answer to this question is C. Next question. All agree that the term stationary potential is synonymous with far field potential. A true, B false. The article I like most often to read about fields and evoked potential is the one that you can see in this frame. It was written in 1997. It defines near field as a wave with clear changes in amplitude, polarity, morphology, and usually latency when the active electrode, that is the exploring electrode, is serially repositioned over small distances. But now comes the big kicker. For all near-field recording, it is assumed that the active or exploring electrode is located in close proximity to the bioelectrical source of interest. In the same article, far fields are also defined. Far fields are defined as maintaining their latency, amplitude, morphology, and polarity even if recorded from far away distance, and they make the point of saying that even if it is performed a whole body length away. A third point made in this article is that far field lack dependence between waveform latency and electrode position, so the term stationary potential is sometimes considered synonymous to far fields. To finish the conversation about fields at this junction, I'd like to remind you that we talked about near and far fields in a video about cutaneous stimulation. but nevertheless, I will now review a few points present in this frame. Electrical fields can be generated by gray or white matter. In the gray matter, electrical fields are due to neuronal soma activation. Near and far gray matter electrical fields are defined based on the characteristic of the recording, not on any intrinsic characteristics of the generator. So one source produces only one field that we will interpret as near or far depending on the positions that we place the electrodes. White matter fields are the result of axonal action potential propagation through the traveling volley which produce a near field continuously through the trajectory of the nerve, and only in certain locations will produce a far field. These locations are those in which the nerve has a physical change in volume or trajectory, or in which there is a change in volume or constitution of the surrounding tissue. So one generator will produce two different fields with different characteristics that can be recorded by using electrodes in different positions. So the answer to this question is B. Next question. Which of the following is more likely to show an isolated P37 with left posterior tibial nerve somatosensory evoked potential? A. CP4 to C5S derivation. B. CP3 to C5S derivation. C. CP3 to CP4 derivation. D. CPZ to C5S derivation. I would like to start with a review of what happens when we use CP4 to C5S derivation. That is what happens when we are doing a posterior tibial nerve stimulation. Posterior tibial nerve scalp potentials are more likely to be picked up ipsilateral to the stimulus than contralateral to the stimulus. The CP4 C5S derivation following left posterior tibial nerve stimulation will capture P31 and N34, which are far fields. This is so because in most individuals, as we have just said, the site contralateral to the stimulus does not capture P37 or N45, and because C5S is silent when we are dealing with leg somatosensory evoked potentials. One thing does not make sense to me regarding the previous comments. If P31 and N34 are far fields and far fields are simultaneously present in all the body at the same time, as it is stated in the volume conductor theory, why are they not recorded from C5S? And if so, why are they not inverted at this electrode, which would correspond to the fact that they are entering the differential amplifier through input 2? That being the case, then the activity that is the far fields capture as CP4 should be cancelled out, because since they are far fields, they would also be captured by C5S, which will invert them. But obviously this is not the case. Now let us consider CP3 to C5S. Using CP3 to C5S derivation with left posterior tibial somatosensory evoked potential, the wave that we will capture will be P31, N34, and P37. CP3 will capture wave P31, N34, and P37, and C5S will be silent. Now let's consider what happened when we use CP3 to FPZ derivation. When using the CP3 to CPZ derivation with left posterior tibial nerve stimulation, we will capture only one clinically significant wave, P37. This is so because of two reasons. First, FPC and CP3 will both be subject to the influence of P31 and N34, since they are both far fields. The second reason is that FPC will invert these waves, thus canceling them out against the P31 and N34 captured by CP3 electrodes. So only P37 will show up in this derivation. Finally, let us consider what happens if we use CPZ to FPC derivation. When using the CPC to FPC derivation in left posterior tibial stimulus, the only wave that will be captured will be P37. This is so because CPC will capture in a fair amount of instances P31, N34, and P37, and FPC will capture only far fields, that is P31 and N34. So they will cancel out, and therefore we will only capture P37 in a significant number of patients. In others, in those that CPC does not capture P37, then we will have a relatively straight tracing with lack of significant waves. It is important to stress that the possibility of capturing a P37 in this derivation, that is using PZ in lead 1, is less than if we were to use CPI as the electrode entering the amplifier through input 1. In this frame, you can see the regular montage used for posterior tibial nerve somatosensory evoked potentials. I have included the corresponding waves to show you P37. Notice that P37 is present in both tracings, that is in the one coming from the CP1 FPC derivation and also in the CPC FP2 derivation. The reason why these two derivations are used, despite their similarities, is that at times it is difficult to find P37, and therefore if we don't find it when the electrode used coming through the input 1 of the amplifier is CP1, we would find it when the electrode coming through the slot 1 of the differential amplifier is CPC. So the answer to this question is C. Next question. Before establishing the absence of P37, which of the following areas must be surveyed? A. CP4, B. CP3, C. CPZ, D. All of the above. In this frame, you can see the positions of CP4, CPC, and CP3. P37 will be present on the same site as a stimulus In this example of left ankle stimulation, most of the time P37 will appear on the left scalp region. Less often it will appear at CPC, and rarely it will be present at CP4. The answer to this question is D. Which of the following waves would you choose as P37? Please take a moment to look at this montage from two different nerves, the common peroneal nerve and the posterior tibial nerve, and select the best answer. The common peroneal nerve was stimulated at the popliteal fossa, and the posterior tibial nerve was stimulated at the ankle. The common peroneal potentials amplitude when stimulated at the ankle are, for the most part, lower than the amplitude obtained from posterior tibial nerve stimulation. The first rule to select the main scalp peak in each of this study is to find the first scalp detected positive wave, which I have indicated here by using the yellow circles in the left common peroneal nerve study, and now in the left posterior tibial nerve study. The second clue for finding the major cortical somatosensory evoked potential wave is to make sure that the main wave, that is, that the main positive wave, is followed by a robust negative peak, as it is the case in this frame and in these studies. Once the first positive scalp wave followed by a robust negative wave is selected, we check timing. Notice that in the left common peroneal nerve study, the main peak occurs at 27 milliseconds after the stimulus, and in the left posterior tibial nerve, the most prominent wave occurs at 37 milliseconds after the stimulus. So the answer to this question is C. Next question. Some authors use the same numerical value for common peroneal nerve somatosensory evoked potential and posterior tibial nerve somatosensory evoked potential. A true, B false. This was the panel I presented to you in the last question. Notice the authors in this case used the label P27 to designate the most prominent common peroneal nerve peak. Yet other authors, to maintain parity with the posterior tibial nerve labeling, they add 10 milliseconds. Hence, P27 becomes P37 and N35 becomes N45. So the answer to this question is true. Next question. Both median and posterior tibial nerve somatosensory evoked potential record activity from all of the following structures except A. Somatosensory cortices, B. thalami, C. cuneatus nuclei, D. plexi. You can see in this frame 3 tables. They belong to 2 different books. The tables are regarding generators of the different waves encountered during median and posterior tibial nerve somatosensory evoked potentials. It appears that there is agreement at times, as it is in the case with N13 and N22. N22 is referred as LP in the illustrated manual that is on your right. But in other, there is significant disagreement as to the generators of the different waves. In the comprehensive clinical neurophysiology, multiple brain stem nuclei are considered the putative generators of N18 and N34, whereas in the illustrated manual, the thalamus is considered the generator of the same waves. So the answer to this question is C. Next question. The thalamus is the putative generator of all the following waves, except A. N34, posterior tibial nerve, B. N18, median nerve, C. N24, common peroneal nerve, D. N22, ulnar nerve. Despite the discrepancy of wave labeling and uncertainties regarding generator, it is important to have a consistent labeling method and a clear framework as to the generators in order to make clinical decisions. In this frame, I have listed the putative generators of the different peaks produced by right median mixed nerve stimulation according to the illustrated manual of clinical evoked potentials. The generator for EP is the brachial plexus. The generator of N13 is the cervical spine. The generator of P13 is the nucleus cuneatus. The generator of N18 is the thalamus. The generator of N20 is the somatosensory cortex. In this new frame, I have just introduced the somatosensory evoked potential for posterior tibial nerve. The first peak corresponds to the action potential propagation of the tibial nerve at the popliteal fossa. The generator of the LP is the cauda equina and also some lower spinal cord regions. The generator of P31 is the nucleus gracilis. The generator of N34 is the thalamus. The generator of P37 is the somatosensory cortex. It is important to remember that ulnar nerve somatosensory evoked potentials are labeled exactly the same way as median nerve evoked potentials, and that the generators are apparently the same. And also that peroneal nerve somatosensory evoked potentials with the stimulation at the popliteal fossa are labeled by subtracting 10 milliseconds from the posterior tibial nerve latencies. The generators are labeled accordingly by some authors. So the answer to this question is D. Just before finishing this talk, I will show you in the next frame a summary of all the waves that may be encountered in posterior tibial nerve somatosensory evoked potentials. Take a few minutes to look over this chart. I have tried to list the most relevant features of each of the waves. Remember that only those that are in red are the ones that we use for actual clinical decision making. I hope you find this chart useful. Thank you very much for your attention.